So after AVRT, now we have to discuss the AVRT, atrioventricular reentrant tachycardias. Here the node is actually involved. AV node is also involved, but the one limb is must be accessory pathway. In AVRT, the both antegrade and the retrograde limb were inside this AV node. That's why we were naming it as a AV nodal reentrant tachycardia. But now here atrioventricular reentrant tachycardia shows that the here node is actually involved, but the one limb of this reentrant tachycardia should be accessory pathway. Here the role of the accessory pathway comes. Okay, so there are AVRT, as it is a long RP tachycardia. There the RV segment should be more than 90 millisecond. And okay, there are the two types of this AVRT. One is the orthotomic ORT and ARTs. Okay, and the most common is ORT. What is the meaning of orthotomic? Orthotomic means you are orthodox. You have to follow the native rules, the native pathway. You have to be straight one. In the antidromic shows that it is opposing the natural pathway. It is actually opposing and it is going against the natural pathway. So we will discuss here that how this circuit works and how this circuit occurs. In ORT, which is actually the most common type of AVRT, is orthotomic tachycardia. And the orthotomic tachycardia AVRT is actually here in which actually this pathway is going through the AV node, and the antegrade limb is AV node and the retrograde limb is accessory pathway. So it is actually following the natural pathway of the impulse, as we discussed in our last lecture, that your impulse has to follow the what is the natural pathway to spread the pulse into the heart is actually from this SA node and this AV node, and then this His fibers, and then this His and the Purkinje fibers. Okay, and then the fascicles. So it actually in ORT, that the black lines, if you are appreciating these black lines, so it is actually following the natural pathway. It is coming down, the antegrade limb is which is coming down through this natural pathway, but it is going upward. It is not going back, or it is going back through this accessory pathway. So in this condition, obviously when it is following the natural pathway, the QRS complex would be narrower. So the differentiation between the ORT and the AVRT is actually very difficult. Why? Because ORT would also be narrow complex regular tachycardia, but most of the time ORT should be more than 200. It should be more than 200. Okay, and AVRT should be around it also be around 200, but ORT should most of the time would be around 200. As you are appreciating it, it is going anti-clockwise. That's why you can say that the movement of this current, which is making circuit between AV node and the accessory pathway, it is anti-clockwise. So the movement of the current in this AVRT in ORT is anti-clockwise. There are the two pathways. One is in the node and other is accessory pathway, and it is going down. The antegrade limb is actually AV node and the retrograde limb is actually through accessory pathway. And this is the most common type of the AVRT. 95% of the tachycardias of AVRTs are ORT. And what is the ART? ART is actually wide complex tachycardias. So whenever you will be looking for the white complex tachycardias, regular white complex tachycardias, you have to exclude the ART. You have to exclude this like SVT with aberrancy. This ART is actually SVT with aberrancy, you can say this. But here, what is the ART? ART is antidromic. It is opposing the natural pathway. It is not going down through the AV node, but it is going down through accessory pathway. Whenever it would be going down through accessory pathway, it will give you the LBB or the bundle branch block of ipsilateral to accessory pathway. If it would be going through this, if suppose that if this patient has accessory pathway between right ventricle and the right atrium, and this impulse is going down through this, then your patient would be have RBB. Why your patient? So just keep one thing, remember that in the ARTs you will have the bundle branch block ipsilateral to the accessory pathway. Why? Because whenever your impulse would be spreading through the accessory pathway, this system like this SA node, this AV node, and this and this Purkinje and this fascicles, then actually you are blocking whenever you will be spreading the impulse through these accessory pathways. It means you are blocking the impulse through here. Why? Because you are activating retrograde. You are activating your heart into retrograde fashion. It means you are blocking the fascicles. That's why you will get the bundle branch block at the ipsilateral to this accessory pathway. If you have accessory pathway at the right side between the right ventricle and the right atrium, you will get the RBB. And if your impulse is going through this left accessory pathway, then you will have the LBB. Okay, so remember this thing. Now you're obviously here, the antegrade limb is accessory pathway and the retrograde limb is AV node, which is against the natural pathway, because natural pathway is through the AV node and it has to spread through the AV node, but it is going against, it is going into the retrograde fashion when it is going antegradely through the accessory pathway and coming up through this AV node. So that's why we called it as an antidromic reentrant tachycardias. And obviously in this, the circuit, the current which is moving through these limbs, antegrade and the retrograde, it is clockwise. Why? It is moving through here and here. So this is in the clock. So the current moving in the circuit between AV node and the accessory pathway is clockwise. It is moving into the clockwise fashion. So obviously, as I told you, because of this accessory pathway, when it comes through this accessory pathway, it's actually blocking the bundle branch. That's why it gives you ipsilateral bundle branch to the your accessory pathways. So what is the symptoms and the clinical signs would be the same as AVRT and AVRT, and the acute treatment would remain same. If your patient has ART and your patient has diagnosed patient of the pre-excitation, then you will not give AV nodal agents. Then the AV nodal agents are contraindicated. If your patient is not diagnosed as a patient of accessory pathway of the pre-excitation and your patient is presenting to you with narrow complex tachycardia, regular narrow complex tachycardia, then you have to give what? You have to give same adenosine or all these things. But if your patient is not, if your patient is known case of the pre-excitation and he or she is presenting to you with any tachycardia, then it is better to, if their patient is hemodynamically unstable, then it is better to give the DC cardioversion, synchronized DC cardioversion. But if you have prokinamide and your patient is hemodynamically stable, then it is better to give prokinamide in the pre-excitation. Okay, so why? Because in pre-excitation, even amiodarone, you can give amiodarone, but in acute termination, amiodarone doesn't work well. That's why. So the drug of choice in pre-excitation is obviously prokinamide. Okay, so you have to give the prokinamide. But if your patient is hemodynamically unstable in any tachyarrhythmia, don't think about it. If it is not VT and VF, just give the synchronized cardioversion. If it is VT and VF, just give what? Asynchronized DC cardioversion. Okay. So this was all about the AVRT and the further treatment of what drugs, what are the drug of choice in these patients. We will discuss in the WPW and the pre-excitation syndrome. We will discuss in detail about the WPW. Here we just discussed about the narrow complex tachycardia, the supraventricular tachycardia. We have discussed the sinus node tachycardia, inappropriate sinus node tachycardias, AVRT, AVRTs. In AVRT we have discussed ORT, ART. Now we will discuss about the atrial flutter and then we will finish our lecture. So our last topic is atrial flutter. We will just do it quickly because the treatment of atrial flutter and all these things are as same as the atrial fibrillation. So we will all discuss all these things in the atrial fibrillation. So first of all, you have to make yourself understand that what is a flutter. Flutter is like the rate is more than 300 or 350. So just keep one thing in your mind, that always mechanical activity follows the electrical activity. So if the electrical activity is 100, then heart has to contract 100 times in a minute. But there is a time when electrical activity like mechanical activity will not follow the electrical activity, when it would be more than impossible to follow that electrical activity. For suppose if atrias are contracting, if the impulse in the atria is coming 24 to 340 times, like if your pulse is coming like your this rate of the atria is coming, atrial rate is coming electrically 240 to 350 times in a minute, then it is impossible to atrias to contract 340 times in a minute. That's why it will not contract at all. It just go into the fibrillations and it just flutters, like it just give this, and this is the fibrillation, and flutter is like it tries to contract, but actually it is not. So without wasting time, we have to go towards the typical and the atypical flutter. The difference between typical and atypical is actually that the typical flutter has good success rate of catheter ablation. However, so the atrial flutter, so there are the two types of atrial flutter, typical and atypical. We have to diagnose it on the ECG in between typical and atypical. Why? Because the treatment is very different from each the treatment of both is actually different from each other. So on ECGs, in typical flutter you will get the negative flutter waves, like these negative flutter waves on 2-3 AVF, but in atypical you will get the positive flutter waves in 2-3 AVF, positive flutter waves in 2-3 AVF inferior leads. So what is the pathophysiology, how it actually occurs, how this how this flutter occurs, and how it is actually coming and going, and how it is actually making a circuit in the heart. So in the typical flutter, it goes and it spreads and it makes a circuit into the anti-clockwise fashion. How? It is actually going down through this cavo-tricuspid junction, like it is the extreme, it is the anterolateral side of atrium. Okay, through the anterolateral side of the atrium it goes down, and this goes up through the intra-atrial septum. This is actually the intra-atrial septum between the right atrium and left atrium. Okay, so this actually occurs between the cavo-tricuspid. It goes down through the cavo-tricuspid and comes up through the intra-atrial septum. So this type of circuit in which the antegrade limb going down through this anterolateral wall of this atrium through the cavo-tricuspid junction, and it goes upward through the intra-atrial septum, then this now obviously this circuit is between cavotricuspid junction and interatrial septum is in anti-clockwise fashion, and this type of the circuit occurs. This type of circuit is made into typical atrial flutters. Okay, and what you have to do is you have to just ablate this from here. You have to ablate it just from here, and that's why the success of the ablation, cryoablation in this atrial flutter is more than 95%. But despite of that, your patient would come into atrial fibrillations in within 5 years. To 80% of the patient post catheter ablation will come to you with atrial fibrillation into 5 years, after 5 years. But the atypical flutter has this circuit. In an atypical flutter, this circuit of cavotricuspid junction and intraatrial septum is actually anti-clockwise. It goes down through this intraatrial septum and it comes up through this cavotricuspid junction. So this, it makes the circuit in clockwise fashion, and this typical flutter makes a junction in anti-clockwise fashion. Okay, in anti-clockwise fashion. So this clockwise flutter is actually this atypical flutter, and anti-clockwise is actually typical flutter. And the common causes and the common condition in which you will find the atrial flutter, because atrial flutter is the most common atrial tachycardia which you will be facing in the emergency rooms, which you do face in the emergency rooms, the post-op, the post-cardiac surgery, any post-op condition, or most of the time post-cardiac surgeries, post-op in cardiac surgeries, post-op patients of cardiac surgeries have these atrial flutters, thyrotoxicosis, and anything which causes the LA enlargement can cause the atrial flutters. So the acute treatment remains same, and yes, one thing more I want to discuss with you guys: type 1 and type 2. Type 1 and type 2 can occur in typical, and type 1 type 2 can occur into the atypical. It is independent of anything, but it just depends on the rate. If your atypical flutter has rate of 240 to 340, you will say that this is the atypical type 1 flutter. But if your patient has a flutter rate of 340 to 440, then you have to say that your patient has a typical but type 2 atrial flutter. So if type 1 and type 2 can occur into atypical or typical, it is just rate dependent. And as we have discussed about the flutter waves, that in atypical you will get the positive flutter with the 2-3 AVF, and in negative you will get the negative, and the typical you will get the negative 2-3 AVF. And the acute treatment remains same: vagal maneuvers, adenosine, beta blockers, and but this all this and if you want to give antiarrhythmic patients for the acute treatment, then the choice of the antiarrhythmic remain same as you will do in the atrial fibrillation. You have to think about the rhythm strategy as you will be thinking in atrial fibrillation, because all treatment of atrial flutter is same, almost same as it is into sorry, as in the atrial fibrillation. But just keep one thing, remember that typical flutter has very good success rate, because you have to ablate here just beneath the cavotricuspid junction. Most of the 95, and the success rate of this typical flutter, the success rate of catheter ablation in typical flutter is more than 95%. But despite of doing all these things, your patient would be presenting to you in 5 years, and 80% of your patient will be presented to you within 5 years or after 5 years with atrial fibrillations. Okay, so these were the atrial flutters and the detailed treatment of anticoagulation, the type of antiarrhythmic which we will be using in the atrial flutter or atrial fibrillation. We will discuss all these things in the atrial fibrillation. Okay, so here we have almost done these atrial tachycardias. Okay, I just want to superficially few more tachycardias, and then we will move towards the pre-excitation syndrome. So as we have discussed all the supraventricular tachycardias, and these are the last one, we have to discuss the atrial tach, and you know that the mechanism behind the tachyarrhythmias is the triggered, reentrant, and the automaticity. So in triggered, you if you just want to rememorize, and you just want to rethink about it, then you will get to know that in the triggered there were two pathophysiologies: DADS, the delayed after depolarization, and the EAD, early after depolarization. Okay, so the triggered in this atrial tach is most of the time because of the DADS, and you know that the DADS were just most of the time because of the CPVT and the ditch toxicity, and the mechanism behind this triggered atrial tachycardia is same. And most of the time these atrial tachycardias would be incessant. They do not respond to our medical therapy, and they despite of giving all the medical therapy, they would be incessant. So in these conditions, the radiofrequency ablation is a choice when it would be incessant, and despite of giving medical therapy it would not be treated. Then you have to do, then the RFA would be the last resort. Then acute treatment, what are the drugs for the acute treatment, how you will terminate it? You have to terminate it with the adenosine, the verapamil, and the drug of acute treatment are the adenosine and all these things. So just keep one thing, remember that these trigger one, the beta blockers are less effective. So the reentrant tachycardias, you know that the reentrant is also a pathophysiology behind the tachyarrhythmias. In the reentrant tachycardias, most of the time the atrial tach, because of the reentrant tachycardias, are mostly with heart diseases. Like these patients are most of the time with the known atrial flutter and the atrial fibrillation with the structural heart diseases, and the rate of almost 70 to 90% with like variant P waves. And in these patients, most of the time with 70 to 90, despite of AV block, your patient would have the rate of 70 to 90 ventricular rate. So in the acute treatment for all these is a beta blocker and the adenosine, and the radio frequency is successful in 75% of the cases. And the anti-arrhythmic drugs in this reentrant tachycardias are ineffective. So the last but not the least is automaticity, and you know that this is a MAT. Okay, MAT, multifocal atrial tachycardias. In this multifocal atrial tachycardias is the example of the automaticity, and this multi-atrial tachyfocal tachycardias are actually having the like multiple foci in the atria, which can cause the tachycardias because of automaticity, because they all foci would produce the impulses automatically. So how you will diagnose it? There are the 4 criteria in which 2 or 3 present, and you can diagnose it through this. You have to look for these 4 things in the patients of the multifocal atrial tachycardia. In the patient of the multifocal tachycardia, the rate should be more than 100, and there should be more than 3 forms of the P waves, and there would be a varying PR, PP, and the RR intervals, and the P waves should be separated by the isoelectric lines. So these 4 things should be in the ECG for the multifocal atrial tachycardia. And how you will treat the multifocal atrial tachycardia? You have to treat the cause only. The cause which is behind, which is the most common cause of multifocal atrial tachycardias are the chronic obstructive lung diseases and the chronic interstitial lung disease. Most of the time lung disease causes multifocal atrial tachycardias in the elderly people. Now you have to treat the cause, and you have to treat the cause, but what you can do for this like tachycardia, you have to give the calcium channel blockers, and if necessary, then the amiodarone would be the last resort. So here we have done all the like supraventricular tachycardias almost, and the next lecture we will do the WPW syndrome, and then the ventricular tachycardias, type of the ventricular tachycardias, and at the end, because we have not done yet the atrial fibrillation, which is also a supraventricular tachycardia, so we have to do the detail in the atrial fibrillation, because atrial fibrillation is a very important topic for cardiologists as well as for the medical people. So just subscribe my channel. I'm your Dr. Nas. Just pray for me, and I'm sure that I have made myself unambiguous for you, and I'm making cardiology and these things simpler for you. So just subscribe my channel and press the bell button for the future updates, and I would hope that you all will be fine, and you all will be enjoying these lectures. Take care. Allah Hafiz.